My name's Cassidy. I'm a nurse practitioner on the supportive oncology team, which is our palliative care team. I don't know how many people that watch this are from Huntsman versus not, but my hope today is to really quickly just like review what palliative care is all about, discuss why symptom management with these patients can be so complicated, and provide a few pearls from the palliative point of view. Talk a little bit about prognostic awareness and why goals of care early and often for these patients can be extremely valuable, and give a few tips on how to introduce palliative care to your patients. That's something that I think we can all bumble with every once in a while. I know you all value palliative care because you invited me to talk, and this interdisciplinary approach that I will be echoing. This is just a quick reminder that palliative care can be helpful from the date of diagnosis of an advanced or serious illness through any disease modifying treatments and into survivorship or end of life. Early involvement of palliative care in patients with peritoneal carcinomatosis is well supported in literature across the board, including papers by our esteemed colleague, Dr. Lambert here. Symptom management for these patients is complicated. They are often very frail, they're malnourished, they have multiple refractory symptoms. They very much require this interdisciplinary approach as well as a holistic view, and that's something that palliative care can offer. We're given a little bit more time with people, and it takes time to separate this web that can occur, because it's rarely just one symptom causing a problem. It's normally this causes that, is affected by this, this, and that, and on top of that, they're dealing with a very serious illness and a poor prognosis that adds a lot of anxiety and existential distress that influences all of these symptoms as a whole. I'm just going to focus and provide some pearls on pain and nausea, because I feel like those are the top two symptoms that a lot of these patients tend to experience that we've encountered. Abdominal pain, for obvious reasons, disease burden, partial obstructions, ascites, bowel dysmotility, and our gut is very sensitive to things like anxiety and distress, which all of these patients are dealing with. The bowel dysmotility can cause some challenges or present some challenges when it comes to pain management and management of any of their symptoms, just because it prevents us from using a lot of the traditional methods of administration. We often rely more on fentanyl patches, transdermal patches, or liquid immediate release products. These can be more readily and easily absorbed or just bypass gut absorption altogether. It tends to be unreliable to use like the tablet form of immediate release products, or especially the long-term release of like morphine or oxycodone. They're just not digesting and absorbing things normally, and those don't tend to be effective, or they just cause problems. Meds with high bioavailability can also be really helpful. Methadone is a bit of a secret tool that can be extremely helpful and can be used as like an adjunct for long-acting pain control. It has 80 to 100% bioavailability in the upper GI tract. Caution is always advised because it is metabolized by like the cytochrome P450 enzymes in our liver, and so it has the potential to interact with other medicines. We always work with our pharmacist pretty closely if we are going to start methadone, and its duration of action and like time of onset varies widely, like sometimes by 1 to 20 hours depending on the person. So we normally start really low and kind of titrate very slowly, but it's a good tool to keep in mind, especially for patients that are really struggling to control their pain with other methods. Dexamethasone bursts are used often and can be very helpful if they're appropriate, if we're not worried about infection soon after surgery or due to their chemotherapy, if they're like at their nadir. A quick burst of Dex has the ability to reduce bowel edema, so it helps with pain, it helps reduce nausea, it really improves appetite, and can do magical things, with some evidence that points to, can help for kind of short-term resolution of a lot of these partial or even malignant bowel obstructions. Unfortunately, often come back, but it can provide relief. Smooth muscle relaxers are always important to consider just because of the spasms and kind of colicky pain that these patients often experience. Um, I put the anticholinergic part there just as far as being aware that the side effects are very anticholinergic and so are probably not the best option if someone's already struggling with like severe dry mouth and constipation. Neuroleptics like gabapentin are a class of medicines that we use often because they can be helpful for more than one thing. Gabapentin, for example, helps with nerve pain, but it can also help with anxiety. It can help with sleep and nausea and sort of gut motility. And never underestimate non-pharm interventions. We're big on those in palliative care. And things like prodigestive spices in their foods, and gentle movement, heat, things like that. For nausea, a few quick tips. Zofran's often really well tolerated, but it can be very constipating. And so it's just valuable to be aware of that. And if that's something someone's struggling with, maybe try alternates to Zofran. Reglan, cautious use if they have diarrhea or obstructive problems. MVPs for me and my favorites tend to be olanzapine or Zyprexa. Extremely helpful for nausea because it hits multiple receptors. Literature shows anywhere from like 3 to 5 of the nausea receptors, whereas many of the other meds only act on 1, maybe 2 of those receptors. Additionally, olanzapine can be great because it helps with sleep, anxiety, and appetite. So it's another one of those things when these patients are already dealing with such a high burden of their care, of medications, it's really helpful and nice when we can find specific meds that can do a great job. Mirtazapine is similar, multiple benefits. And haloperidol is cheap, very effective for nausea, not very sedating at the lower doses. I know most of us probably only have experience with Haldol in higher doses for like really agitated and delirious patients. That is not its only role. So we use it a lot for management of nausea. And then Dex bursts, again, have the nausea benefit. Octreotide and any of these anti-secretion agents, there's pretty mixed evidence. There's a lot of newer, like from 2005 to 2008, clinical trials or randomized controlled trials that compared octreotide versus normal saline in addition to like standard of care. And it unfortunately, in those studies at least, didn't seem to be as helpful as we originally thought. But mostly well tolerated with maybe just some increased colicky pain. So could be worth an option as kind of a treatment for nausea that's refractory to previous and other interventions. And again, those wonderful mind-body interventions and non-pharmacological things can be extremely helpful for these patients who are just grasping for anything that might help them feel a little bit better. So we'll see if this works. I don't know if when I shared my screen, I did it correctly to share sound or not, but we'll try and see if this works.
Hi, we got a call that this
Can you guys hear that?
Yes.
Okay.
house is on fire. How can we be helpful? Well, the house is on fire, but I'm worried if you go in there, it might send the wrong message. Wait, what? I'm with the fire department. Yes, I know. I think you could be really helpful, but I think the family might be worried something is wrong if the fire department shows up at their house. But something is wrong. Their house is on fire. Do you think there's any way you could talk to them, but not use the word fire? What? I just think if the family hears the word fire, they might lose hope. But I am with the fire department, and I am here to help this family with their fire. Right, totally. I think you could be really helpful, but I'm just not sure this family is in a place where they're ready to meet the fire department right now. Can we call you the water support team?
Oh my gosh, now I can't figure out how to go back into full mode. Sorry, bear with me for a second. What's happening? Who knows how to make it go back into like full present mode?
Oh, maybe
You got it. You
got it.
figured it out.
So that's just a funny PSA that is, a lot of the myths about palliative care that, people are really resistant to get us involved sometimes because they think that we're just going to go in and really freak the patient out, then tell them that they're going to die and should go on hospice. And that is not our role or our goal. And, mentioning and talking about where people are in their illness, what's important to them, and maybe helping them focus on those values in terms of their like prognosis and what your assessment of what their future might look like is extremely valuable and important. So these goals of care should be started early and are often ongoing. It's not uncommon for goals to change. And so just because you've sort of talked to a patient in their first visit with you and they've expressed that, they're really willing to fight and they will do anything to stay alive and throw whatever you have at them, doesn't mean that, 6 months later when they are admitted for the 6th time in that 6 months and they're miserable and they're vomiting and they're nauseous and they're in pain and they're not sleeping and they're anxious and they've run through multiple lines of chemotherapy, maybe they're post HIPEC and they're just, really in your assessment, the best thing for them might be to focus on their quality of life, because any interventions that we provide would have a high potential to be more harmful than helpful. There's always room to readdress these goals. And if we've started this type of conversation early, it's a lot less scarier for people to talk about, when it comes back up. And so additionally, if you look at a patient and you ask yourself, would I be surprised if this patient passed away in the next 6 months? And the answer is no. Then, palliative care, or if you feel comfortable having a goals of care discussion with that patient, is extremely valuable. It allows them to feel more empowered. It allows shared decision making, and it makes crisis periods much easier to manage and less distressing, because the patients feel like they had some idea that, okay, this could be a possibility, and I feel okay about, refocusing and fighting for a good time with my family, or whatever their reasons are for wanting to still be here and keep going. And some quick tips for introducing palliative care. This wording can be tricky and is hard for all of us no matter what. A lot of times people don't know what palliative care means, like what palliative is, or if they do, they again just associate it with hospice and death. So it can be helpful to introduce it in more of a, I think we could do a better job managing your symptoms. So I want to ask my colleagues in supportive oncology to start working with us, or in better job managing your symptoms and helping you understand your choices. If they are, they don't know if they want to move forward with having a venting G-tube placed and try to go on TPN, if the survival isn't going to be, spent in a way that they value and find important. Another option, I think it could be helpful, to have you meet with our supportive oncology or palliative care team. They specialize in symptom management and help with communication to make sure that the treatments you receive match your values and goals. It's helpful to notice, for anyone not part of our institution, that each hospital kind of uses their palliative care team a little bit different way. Our supportive oncology team does do a lot of symptom management as well as goals of care, versus our palliative care team at the university tends to focus more on like family meetings and goals of care. So it's just important to kind of know, depending on your institution, what the role of your teams are. So quick summary, symptom management is really complicated for these patients. Thinking about interventions that can help address multiple symptoms can be helpful. GI tract dysfunction, especially as end of life approaches, requires special attention to pharmacology, as well as the high anxiety and kind of existential distress that can accompany it. And it's important to readdress goals of care with any change in disease or treatment or their prognosis. This is really valuable because it helps support your patients with a renewed understanding of where they might be and what their future might look like. And that's it.
Great.